Assalamu alaikum. Good morning, everybody. I am happy to be here in Indo-ISMA International Conference for the 5th time. This is a very good concept and a very good idea to highlight the issue of reproductive endocrinology, which is missed in our clinical practice mostly. We are going to talk today about the premature ovarian insufficiency. This is my disclosure. This is my agenda. Simply, premature ovarian insufficiency, it is a matter of hypergonadotrophic hypoestrogenism, which is presented mostly with oligomenorrhea or amenorrhea for at least 4 to 6 months. Its prevalence is different in different areas in the body, in the world, but mostly its prevalence is 1%. In India, the most high prevalence is 5.5. In Italy, it is about 1.8, and in Iran, 3.5. No other data I found regarding the prevalence of premature ovarian insufficiency in the other literature. The most common risk factors for premature ovarian insufficiency are bad nutritional status, smoking, poor socioeconomic status, under or overweight patients, nulliparity, and irregular menstrual cycle since menarche. These are the most common causes of premature ovarian insufficiency. Either it is spontaneous premature ovarian insufficiency, mostly idiopathic. Genetic causes can be there in the form of Turner syndrome, Fragile X syndrome, and other genetic abnormalities. It may be associated with some autoimmune diseases like adrenal cortical autoimmune diseases, hypothyroidism, autoimmune hypothyroidism, celiac disease, type 1 diabetes, and the other autoimmunities. Inborn error of metabolism can be one of the causes of premature ovarian insufficiency, as galactosemia or 17-alpha hydroxylase deficiency. Infectious causes as mumps and other viral infections could be also contributing to the etiology of premature ovarian insufficiency. Iatrogenic causes. Those patients who are receiving chemotherapy for cancer or receiving chemotherapy for some autoimmune diseases like systemic lupus erythematosus, especially those patients receiving combined chemotherapy and radiotherapy, they are at risk of development of premature ovarian insufficiency. Oophorectomy is another iatrogenic cause. Those patients usually present with oligomenorrhea and menorrhea for 4 to 6 months, with some manifestations due to estrogen deficiency, psychoaffective changes like mood lability, insomnia, irritability, and vasomotor disorders, and some urogenital disorders due to vaginal atrophy or low libido or dyspareunia. How are we going to diagnose premature ovarian insufficiency? It should be considered in all patients presenting with oligomenorrhea and menorrhea before the age of 40. And those patients who have primary amenorrhea by the age of 15 years should be considered for evaluation for premature ovarian insufficiency. But when you are going to evaluate for this condition, those patients should not be on contraceptive pills or hormonal replacement therapy. It should be stopped 6 weeks before starting evaluation. The routine use of anti-Mullerian hormone is not indicated in treatment in diagnosis of premature ovarian insufficiency. This algorithm is usually used in Australia for the diagnosis of premature ovarian insufficiency. I found it is very good, and it can highlight how to approach the diagnosis with the history taking regarding the presentation of the patient, the history of any operative interference, past medical history of cancer and management with chemotherapeutic agents or radiotherapy, the use of contraceptive pills or hormonal replacement therapy, and the history for any possible cardiovascular problems, which is very important to be addressed in the management of premature ovarian insufficiency, must be considered. Those patients who present with oligomenorrhea or amenorrhea for 4 to 6 months before the age of 40 should have their FSH level to be measured. Human chorionic gonadotrophin beta, human chorionic gonadotrophin to rule out pregnancy also should be evaluated. Pelvic ultrasonography. If the FSH level is above 25 unit, and it should be measured twice with 4 to 6 weeks apart. If it is like this, premature ovarian insufficiency is confirmed. If it is not, you should evaluate for other causes of oligomenorrhea or amenorrhea. Those patients who are diagnosed with premature ovarian insufficiency, you should take good history regarding the exposure to chemotherapeutic agents or irradiation or any past history of operations for the uterus or the ovaries. If it is there, it is a matter of iatrogenic premature ovarian insufficiency. If it is not there, spontaneous premature ovarian insufficiency should be considered. Here you are going to test for karyotyping to rule out Turner syndrome or other chromosomal abnormalities. If karyotyping is normal, you are going to test for FMR1 pre-mutation genetic analysis. If it is abnormal, fragile X prematuration carrier should be considered, which is associated with premature ovarian insufficiency. If it is normal, baseline autoimmune screening should be done according to the clinical scenario. If it is normal, it is idiopathic. If it is abnormal, you are going to manage according to the abnormal autoimmunity there in the patient. What are the long-term consequences of premature ovarian insufficiency? Those patients may have accelerated cognitive impairment, accelerated cardiovascular disease, autoimmune diseases, adrenal, thyroid, celiac, whatever the associated autoimmune disease with the condition, patient by patient. Infertility, osteoporosis, or premature mortality could be there. How to treat? Psychological support is very important for patients with premature ovarian insufficiency. Those patients actually, for the control of vasomotor abnormalities or the possible development of osteoporosis, hormonal replacement therapy is indicated. By the way, some cases of premature ovarian insufficiencies may still have the possibility to get pregnant spontaneously in 5 to 10% of the cases. Some of the patients, they are not willing to get pregnant. If they are not willing to get pregnant, contraception should be used. If they are not willing to get pregnant, you are going for hormonal replacement therapy till the age of 50, which is mostly the age of normal menopause. In patients who have primary amenorrhea and absence of menarche, pubertal induction will be the option for hormonal replacement therapy. If no pubertal induction is needed and the patients have previous hysterectomy, continuous estrogen hormonal replacement therapy is indicated. If no hysterectomy, you are going to use combined estrogen, progesterone, either in cyclic manner or in continuous manner. But if you are going to use hormonal replacement therapy, you should consider proper follow-up of the patient for the side effects of the replacement therapy. You are going to see the patient after 3 months of the start of hormonal replacement therapy for evaluation of side effects and response to therapy. If everything is going well, you are going to follow your patient annually. You are going to evaluate for cardiovascular risk factors and manage properly. You are going to evaluate for osteoporosis and manage properly. And if you have any autoimmune disease, you should consider in the management of your patient. For patients who have, for example, positive autoimmunity for hypothyroidism, you are going to check TSH level for the patient annually. And if the patient has anti-adrenal antibodies, you should consider evaluation and management for Addison disease. This is very important issue also, which is the follow-up parameters for patients on hormonal replacement therapy. Usually those patients who have premature ovarian insufficiency, they have low risk for breast cancer or cardiovascular disease than those who are postmenopausal at the usual age. But you must consider annual evaluation for cardiovascular risk. You must consider screening for cancer breast in those patients according to the local guidelines. And you must consider swabbing for the cervical cancer also. These are the common hormones used for replacement therapy. The estrogens, the 17 beta estradiol in 2 milligrams per day, conjugated equine estrogen 1.5 milligram per day, and transdermal estradiol 75 to 100 milligram per day. Micronized progesterone can be used continuously 100 milligram per day or cyclical for 12 days per month 200 milligram per day. Areas to be resolved in primary ovarian insufficiency which are not well settled. The role of mesenchymal stem cell transplantation is well established in animals, in animal studies. But what about humans? This should be established in human studies to reverse and maintain ovarian function in those patients with premature ovarian insufficiency. Worldwide, awareness of premature ovarian insufficiency is lacking, with missed opportunities to improve patients' outcome. Healthcare systems are not considering premature ovarian insufficiency as a priority. I think many of the attending doctors, for the first time, they hear about premature ovarian insufficiency. Wise hormone replacement therapy policy will close the great gap in the treatment of premature ovarian insufficiency. In conclusion, premature ovarian insufficiency is the loss of ovarian function in women under the age of 40. Premature ovarian insufficiency has great impacts on women's psychological and physical health. Diagnosis is determined by elevated FSH level, but it is often delayed up to 2 years. Individualized hormone replacement therapy should be instituted promptly and continued until the usual age of menopause, usually till the age of 50. Women at risk of premature ovarian insufficiency should be referred for counseling and potentially fertility preservation. Those patients who are going for chemotherapy or radiotherapy for cancer management or chemotherapy for treatment of some autoimmune diseases, as we said, they should be counseled for preservation of fertility, either with oocyte cryopreservation or ovarian tissue cryopreservation or embryo cryopreservation. Women health care clinics and the clear hormonal replacement protocol should be established. We are missing the protocol of hormonal replacement therapy. Many of the doctors, they are not addressing the role of hormonal replacement therapy in their practice. Either they have no experience in hormonal replacement therapy, or they are afraid of the attitude of our patients who are not following regularly or properly with their doctors. Again, women health care clinics and the clear hormonal replacement therapy protocols should be established, and thank you.